Organ transplantation. Now, the way organ transplantation works is we take a cell, a tissue, or a solid organ from one person, give it to another patient. How's that going to work?
They have to be compatible.
All right. So they have to be of the same HLA, correct? So what is HLA? That is a human leukocyte antigen. Long story short, it's basically a protein ID on the surface of each and every cell. So let's say Kurt. Kurt's every single cell in his body has the same HLA, meaning as his white blood cells travel around his bloodstream from his head down to his toes, whenever they bump into other cells, they recognize each other because they have the same HLA. So when cells make contact, specifically your immune system cells, make contact with another cell, they identify each other because of the human leukocyte antigen, because of that protein ID. Any questions so far? Right. It's unique to every individual. So therefore, if a patient has, let's say there's a virus, a bacterium, or a fungus that comes in, can your immune system kill them? Yes, they can be identified and fought, right? Targeted for destruction, because once they bump into any immune system cell, they will be identified as, oh, that's foreign. I have to destroy that thing. You understand? Okay. So the only identical HLAs between two people are between or among identical twins or triplets, quadruplets, etc. Because they came from one single egg, correct? So they have the same identity because they came from the same egg. So if you compare, let's say if Shanice and Milagros are twins, identical twins. So when I compare their cells under a microscope, they look identical because they are identical twins. Not the same, doesn't apply to fraternal twins because fraternal twins, there are two separate eggs. All right. Any questions so far? Now, how many of us have identical siblings? Do you have a twin? Anybody here? No, it's rare, right? So not everybody has an identical twin. So should you require a transplant, a cell, tissue, or solid organ transplant, what do you have to contend with? A close enough match. All right. So we will have to just live with, okay, that match is close enough. All right. So that's the principle of transplantation. Now, since it's not an exact match, will that cell, tissue, or organ ever be recognized as self? No. Never. So all through that graph, so we'll call the tissue, cell, or organ that is transplanted to another person as a graph, okay? For discussion purposes, that's what we'll call it. So the graph, as long as that graph lives in the host, so we'll call the recipient as the host. So as long as the graph stays in that host, will it always remain a foreign object? Yes. For all purposes, that's the fact. Okay, that's what's going to happen. So therefore, how do we keep the graph alive? How do we keep it from being destroyed by the host immune system? Okay, very good. So we will have to give the host a slew of immunosuppressive agents. All right. So from before the transfusion, during the transfusion, and then forever, as long as the graft stays in the host has to keep taking immunosuppressive agents. All right. However, it's not a guarantee. So there will always be a chance that there will be rejection. We'll use the kidney transplantation as a example today because there's really no separate chapter wherein they discuss all of the transplants. Every transplant is discussed in every chapter. So the most commonly transplanted organs are kidneys, liver, heart, lungs, eyes, and bone marrow, right? So meaning when we say bone marrow, that we're referring to stem cells, okay? So this chapter is under the kidneys, under end-stage kidney disease, because one of the management is kidney transplantation, correct? Right. So we're specifically under medical management after a kidney transplant. Again, very rare do we get a transplant between identical siblings. Okay, so most of our transplants are, of course, from non-identical siblings. Okay, so totally unrelated donor and host. Okay, so we discussed that the only way to keep the graft alive is to immunosuppress the host. All right. This is not part of the test, but just describing to you in the case of a kidney. So if the host kidneys are diseased, let's say end-stage kidney disease, they're alive, but they're not functioning. You understand? I mean, they're there, receiving blood flow, receiving oxygen. They're living kidneys, but nephrons are non-functional. So we do matching, blood type first, and then we look at HLA, tissue studies, and then we find, oh, this will work. Okay, this is close enough match. So they give the host and the donor both immunosuppressants because we don't want any white blood cells going from the host, from the donor going into the host body, right? So both the donor and the host recipient will be immunosuppressed for a certain period before the surgery. And then finally comes surgery time because look at the size of the renal arteries and veins. They're huge, right? So it's not safe to use those. They're going to be losing too much blood if we use those large organs. The iliac and the iliac arteries, however, are way smaller, so we'll use those. And you see here the donor kidney. This is now the graft. So it comes with its own ureters and its own renal artery and vein. So we'll connect them. We'll put them in a pocket here, the pelvis. So your bowels will be here. You have small intestines here, large intestine. So we'll put them there and then attach. And then blood flow will start going into the kidney and it'll turn pink. And then it'll start working. All right. However, it doesn't always work like that. So despite all the testing and immunosuppression to prepare for the surgery, rejection can occur. There are 3 types of rejection. What is rejection? Okay, so it's the process by which, because again, the graft does not have a matching HLA as the host, so it will always remain a foreign body. So it is a target for destruction by the immune system. There are 3 types, as I said. The rarest of the 3 rejections is hyperacute. Why rare? Because did we just do this overnight or did we do our due diligence of testing? Yes, we did that meticulously. Okay, we made sure everything is okay. We made sure that there's a close enough match. We made sure there was adequate immunosuppression before we did surgery. So comes surgery day, hyperacute rejection is simply a freak of nature, meaning it's not supposed to happen, but yet it happened. So we will answer 3 questions for every type. First is, when does it happen? Next question is, what exactly happened? And third is, what can be done about it? Again, what are those three questions? When, what happened, and what can be done about it? So first, hyperacute. When does it happen? Within 24 hours. Doesn't mean it has to reach 24 hours. Usually it occurs, most cases, most of the very rare instances that this happens occur right there in the operating room. Patient doesn't even make it out of the operating room table. So what happens is here, immediate antibody-mediated reaction that leads to generalized glomerular capillary thrombosis and necrosis, meaning clots form. Is something inside the graft reacted with the host and triggered widespread clotting. Clots formed in every single capillary of the host, of the graft. So what happens if all those blood vessels are covered with blood clots?
There's no blood flow.
No blood flow, so what happens to the graft? Dies right there before the surgeon's eyes. Sometimes they make it out of the operating room, but then they have symptoms. We'll look at the symptoms shortly in the recovery, right? So this happens within 24 hours. What can be done about it? Nothing. The graft is dead. So what do we do? Take it out, put it on the grill, whatever you want to do with it. Okay, it's gone. Okay, it can't be used anymore. Any questions about hyperacute? Let's go now to acute. Acute rejection occurs within 3 to 14 days after the transplant. Or to put it more accurately, it doesn't really occur once. Acute rejection can occur repeatedly throughout the life of the graft. Let me explain. So in acute rejection, it's simply a cytotoxic activity by the host immune systems, usually by the lymphocytes. So what happens in acute rejection is, again, let me repeat, there's no exact match, correct? So therefore, it's a foreign object. So despite the immunosuppression therapy, meaning the patient keeps taking the immunosuppressants, at some point, will the therapy be adequate or can it be ineffective? Let's say the patient got sick or the patient was taking something that weakened the immune system further. Can that happen? Let's say if Miss Peters received a kidney, and then let's say we were going out, right? Then suddenly she found out that all this time I was cheating on her. So what does that do to her stress level?
Very good.
Okay, then what happens to her immunity? So suddenly, did the medication she was taking enough to keep the body from rejecting the graft? No, right? So things happen during a person's the host life. So therefore, can it be possible that the lymphocytes now have a chance to attack the graft? Yes. So it's during these times that we need to identify, well, is it occurring or not? We'll get to the signs and symptoms shortly. So because we need to recognize it as soon as possible so that the intervention is really to increase the dosing of and the number of immunosuppressive agents. So during an acute rejection, usually we increase the doses, plus we place the patient on high-dose steroids, IV steroids, to stop the reaction, okay, to suppress the immune system even more and to stop it from killing or destroying the graft. Any question? So that's it. When does it occur? 3 to 14 days and sporadically throughout. Okay, never stops. Okay, as long as that graft is in there, there's always a chance of acute rejection. And what exactly happened? The lymphocytes, were trying to destroy the graft. That's what happened. And then what can be done about it?
Antibiotics and
Not antibiotic. There's no infection here.
steroids.
Okay, we increase, we medication management basically is the answer. Okay, we increase the dosing or add more. All right. Yes,
Do these people always live in like fear of getting sick?
Yes. Basically. You remember Cushing's?
Yeah.
From last week? Yes, same thing. So the Cushing's people, no, sorry, Addison's. Okay, Addison's people who are taking steroids for life, right? Yes, they live the same way. They're always at risk for
Risk for infection too.
right. So same thing as who else takes immunosuppressants? What about people who have
Also, the
Crohn's disease? Because those are the people that take immunosuppressants, right? Lupus patients. Who else? Right, arthritis, COPD, asthma patients. So same thing, right? There's so many people taking immunosuppressants or steroids. Lastly is chronic. Chronic after many years. So this could be months or years after the transplant. Now, what happened here? Because again, it's you have a basically you have a living a foreign object living in your body, correct? That's basically what's happening in a transplant. So does it cause inflammation? Let's say you have a splinter in your finger. Okay, same exact reaction, right? I mean, will it cause inflammation? Yes. So there's always some degree of inflammation as long as you keep that graft in there. So this can go on for so many years. So when we have inflammation, what happens around the area of inflammation? Okay, so there's vasodilation there, correct? So therefore, if there's vasodilation and swelling, will it cause some local tissue destruction? Yes, little by little, right? So little by little, the graft, cells in the graft eventually die because of the inflammation, but not at the same time. No, little by little, over so many years, over so many decades, if the graft stays that long. Eventually, what will happen to the graft? So is it different from what happened to this patient in the first place before they got the transplant? What's the difference? Because let's say a kidney. So let's say Miss Peters, why did she require a transplant? What happened to her kidneys? Because she had what? Diabetes, maybe, heart disease, right? Or hypertension. So that destroyed her kidneys. Did it destroy it overnight? Or a couple hours ago? No, it took years and decades before it was destroyed. So here, this graft, which has chronic rejection happening, did it happen overnight? Over years, decades as well. So is it any different from the status quo? No, it's exactly the same. So therefore, what can be done about this? What did we do before she got the... Yeah. So what did we do to her? Did we protect her from harmful substances? Like, did we preserve what was remaining function of her kidney? Yeah, exactly. So it'll be like treating the ESKD like before, because this is basically what's happening now. So this kidney is starting to fail as well. So we can do whatever we can, conservative management, stop, drinking all this bad stuff, the medication, stop these NSAIDs, okay? That's harming your kidneys, okay? Stop the alcohol, okay? And then until comes time, oh, now it's gone. So she'll be back to dialysis again. Can she get another transplant?
Yes.
Yes, if she's lucky, she gets another match. Okay, yeah, she's a candidate again.
So how long does that take? If
We have no idea.
Yeah,
Yeah, because there's a match. Although there is a national kidney donor network, meaning, let's say if you can find a willing donor. So let's say Kirko is your friend, and Ms. Kirko wants to donate a kidney to you, but you're not a match. If you go to that network, they'll just simply say, oh, we have a willing donor. Okay, we'll take your kidney and we'll guarantee we'll find you one. All right. because that's how that network works. Okay, so it's an extensive, okay, all over, not just all over the country. They go overseas as well. Okay, that's how extensive that network is. So that's how they guarantee you if you have a willing donor here. Guaranteed a living donor. Oh yeah, we'll find you. We'll give us a couple weeks. We'll find you one. Okay, and we'll take that kidney, give it to someone else. Does that make sense? All right. And anyway, that's not our testing. So our testing is with hyperacute, acute, and chronic rejection. So with chronic rejection, can we also increase the immunosuppression? Yes, but will it stop the reaction like it did acute rejection?
No.
No, it will just delay the inevitable, right? At least buys Miss Peters time, until she goes back to dialysis. That's all we can do. Now let's go to the manifestations. Oh no, so drug therapy is on table 48-4. So these are the medications. So we've got 3 groups here. We've got calcineurin inhibitors. We also have anti-proliferatives. And then, of course, we have steroids. So calcineurin inhibitors, so they inhibit helper T cells because this is a targeted therapy, meaning not all of your immune system cells are involved in organ rejection. It's only certain cells. Let's say, for example, tacrolimus targets T lymphocytes because T lymphocytes are the ones that actually destroy the graft. They're involved in organ rejection. And these are your side effects. These drugs cause kidney toxicity, hyperkalemia, neurotoxicity. Cyclosporin, another calcineurin inhibitor. Okay, again, targets T cells. Sirolimus, mTOR inhibitor, same thing, targets T lymphocytes. Mycophenolate, this is an anti-proliferative. When we say anti-proliferative, what does proliferate means? Cell division, right? Yeah, so it targets cell division or cell multiplication. So is this specific though? Is this like cell specific, like it only targets it in certain cells? Unfortunately, no. So yes, it can inhibit T and B, but are T and B lymphocytes the only ones that rapidly divide? No. It also targets all other cells that are rapidly dividing. So look at the signs and symptoms. Are your GI tract cells rapidly dividing? When you get a chapped lip, how long does it take to heal it? Overnight. You put petroleum jelly before you go to sleep. The next day, you peel it off, right? So there's your evidence that your GI tract cells are rapidly dividing. I mean, how long do sores in your mouth last? Only a couple days. It heals so fast because the cells are rapidly dividing. So that's true from your mouth all the way to your rectum, right? Have you noticed that, let's say you get diarrhea today, your butt's so sore, does it last long? No, just after several hours or overnight, the discomfort's gone, right? Because again, your GI tract is rapidly dividing. So they are affected. So you get GI upset, diarrhea. Okay, do not crush. Plus, it also causes, look at this. Look at the effect on CBC. Why does it affect your blood cells? Will this affect the bone marrow?
Right.
Mycophenolate, does it affect the bone marrow? It targets rapidly dividing cells. So yes, yeah, the bone marrow cells are rapidly dividing. And then the problem with, so all these drugs are on the market. The problem with steroids, again, that's what we use during a rejection episode, acute and chronic rejection. The problem with steroids is they're not cell specific. They target everything. So which one will have I mean, you already saw the effects last week. What was the effect of steroids taken for a long time? The Cushing syndrome, right? Yeah, so you saw the moon phase, the buffalo hump, the abdominal obesity, the edema, right, etc. The thinning of the skin, the uh, brittleness of the bone, and then the hair growth in females, and then immunosuppression and the peptic ulcer risk, right, because of the increased acidity. All right, so that's let's look at the manifestations here for kidney. The rejection should be, there should be a table somewhere. Although it's mentioned in the paragraph, but I'm sure it has a maybe not. But anyway, so let's just use common sense. If the patient has acute kidney rejection, are the symptoms that of AKI or CKD? AKI, because it happens so quickly, right? Just keep it like that. So therefore, chronic rejection will have what set of signs and symptoms? CKD. Okay. And I won't repeat that. You did that last semester. That's it for organ rejection. Let's do just one more topic, and then that's it for today. Let's go to lupus.
It was 3 medications or 4?
There were 5 on that table.
It's six. You doing all 6 on our test?
Sorry.
On the quiz, I mean, sorry. No.
Yeah, we have Cushing's from last week.
Medications for the, immunosuppressant.
Yeah, there were 5 listed on that table. Right?
6, that's all there.
Okay, 6. All right, here's lupus. There are 2 types of lupus. There's the discoid lupus, and then there's the systemic lupus erythematosus. The difference between the two, this one obviously is systemic. The discoid one, which is less popular, meaning it occurs less commonly than SLE, only involves the skin. What is lupus? It's a connective tissue disorder. It's inflammatory, autoimmune. It affects almost every organ of the body, because name one body organ that doesn't have connective tissue. Nothing. Blood is a connective tissue. Blood vessels are connective tissues. Your joints are connective tissues. The skin is the largest connective tissue. Every membrane in your body, the peritoneum, the meninges, the pericardium, the fascia, they are all connective tissues, right? What do connective tissues serve as? Keeps everything together, right? Holds stuff together, right? Because imagine an organ that doesn't have connective tissue. How will that stay together, right? If you think about it, like say muscle, without tendons, the fascia, and the cartilage, can they be held together? No. So we are all made of connective tissues. So this disorder causes inflammation in all of those connective tissues. Affects more women than men, and affects these ethnicities more. So for the discussion here, we're only discussing SLE, the systemic type. We're not discussing the discoid. Again, discoid is rare. So it's autoimmune. So do we know what causes it? No idea. Okay, so let's skip through that. All we know is we have autoantibodies that attack and destroy connective tissues throughout the body, causing systemic inflammation. Let's go to the, I'll go back to the clinical manifestations, but let's look at the testing first. So how do we test for lupus? It's not easy. because there's no blood test that gives us a definite diagnosis. Okay, meaning it's clinically diagnosed. So the doctor will have to do a bunch of tests, and then the testing mentioned here is more to rule out other causes. No, all we can do is this, are we sure this is not rheumatoid arthritis, or are we sure this is not systemic sclerosis? Because the symptoms resemble other disorders, because these patients have joint pain, abdominal pain, so they resemble rheumatoid arthritis, right? So they do testing to rule out other causes. And then based on your set of signs and symptoms, they in fact have a scoring criteria. Then they make a diagnosis. Manifestations are the following. As I said, is there a body system that doesn't have connective tissues?
No.
No. So your patient has symptoms of lupus from head to toe. So starting from the hair, because the skin holds your scalp, correct? So therefore, there's inflammation there, so you lose some hair. The early manifestations is this rash around the cheeks over the bridge of the nose, forming a butterfly pattern. So we call it a butterfly rash. Although you can easily cover that with cosmetics, as long as they're cosmetics that have moisturizers, not the cheap ones. So you can cover that and won't have any, because it's unsightly. Okay, so you have that distinct rash over your face, and then you go out. Because we forgot to mention, what age is the peak for this disease?
No.
Actually, younger than that. Yeah. So we can have here in the 20s to 40s. Okay, similar to hyper rheumatoid, same as rheumatoid arthritis, and also with hyperthyroidism. Okay, so same age of onset. Please read the
damage too, right?
Yes, so the most frequently damaged organ here is the kidneys. Kidneys have a lot of connective tissues in it. The heart, the lungs, the GI tract, the joints will all be affected here. The patient can have inflammation with all those membranes I mentioned, meaning can the patient have pericarditis? Can they have pneumonitis, peritonitis? All of those are possible. Okay, however, the most common and debilitating complication is lupus nephritis, meaning the patient this is one of the causes of end-stage kidney disease. Patient loses kidney function and will require kidney transplant. Until then, though, they'll go on dialysis. So this is one of those causes other than diabetes and hypertension. Okay, so let's say you have patients on dialysis and they're non-diabetic, non-hypertensive. This could be the reason they lost their kidneys. All right, could be from lupus. So I won't read the whole thing for you. So there's the lupus nephritis, splenomegaly, pericarditis, myocarditis, to osteoporosis, all the way down. Again, because the largest connective tissue in the body is the skin, most of our prevention, because this is a chronic condition. So our goal for therapy is to put the patient in remission, meaning we keep the disease in check, just like heart failure or renal failure. Okay, it's a chronic condition, so all we can do is maintain it, keep it from flaring up. So exacerbations or flare-ups are caused or precipitated by stress. But again, because the largest connective tissue is the skin, any skin irritation, including sun exposure, can trigger a flare-up. A flare-up can cause debilitation. Patients will have all these symptoms we mentioned here, but magnify it by 10 times. Okay, so severe joint pain, severe rash, severe everything. Okay, that's what a flare-up will be like. So therefore, the best prevention of a flare-up is really to protect the skin, because again, that's the largest connective tissue. So that's the number one trigger for a flare-up, meaning the patient goes to the beach, for instance, forgetting, oh, I have lupus, I can't do this, right? But they can still go out, but make sure they stay out of direct sunlight. Okay, they can wear, because can you totally avoid the sun? No. So yeah, do they have to wear sunscreen? What SPF number?
50.
Okay, 30 or higher. So if the higher the SPF, the better the protection. Let's go to management now. Because it's an autoimmune disorder, what do you think is the main treatment? Immunosuppressants. Okay. Steroids, we don't like steroids because besides Cushing's syndrome, can this also precipitate illness? Yeah, illness. Okay, so we don't want them to get infection, because can an infection cause an exacerbation? Yes, that will trigger another flare-up. So we will use, just like with organ rejection, we will use cell-specific medications, right? Rather than steroids all the time. So steroids are reserved only for acute exacerbations, meaning you come to the hospital because of a flare-up, then we'll place you on steroids. You with me? All right. So here's the treatment. So we have a lot of medications. Because the patient has pain, joint pain, abdominal pain, back pain, so we will have to give them NSAIDs. So this is one group of people, and then we already concluded peptic ulcer disease. So besides NSAIDs, what do you think will be given to protect them from developing peptic ulcers? Okay, either PPIs or misoprostol. Okay, but with misoprostol, again, these are young folks, right? These are young ladies here. So what? Okay, so make sure you do a pregnancy test and make sure they stay non-pregnant. Okay.
And if they do become pregnant, then they gotta stop, right?
Stop what?
Medication.
That's a catch-22, because it's not easy to be off the medication. Okay, so they need the medications precisely to keep the disease in remission. So the patient will have to make a decision here. They want to carry the pregnancy to term or terminate the pregnancy. That's their decision. One warning though, what the doctors will advise them that whether they take the pregnancy to term or terminate it early, once they get pregnant, they will have a flare-up. Okay, so the data shows, the statistics show it doesn't make a difference. So if they got pregnant and they chose to stop it because they don't want to flare up, they're gonna have a flare up anyway. Make sense? So again, the patient has to make that decision. But the whole point of the thing was to really keep from getting pregnant, especially when they're getting a flare up. But do lupus patients have children, have families? Yes, of course. Yeah. I know a lot of people with lupus. They have children. Okay, they have families. They just need to schedule and plan the pregnancy really well, right? So let's say, when is the sun hottest? What months? Okay, so therefore they need to schedule the conception so that the pregnancy would avoid summer and spring, or at least the latest would be you give birth around spring.
So
Okay.
get pregnant like in August and give birth.
Yeah, well,
like
you do the
April,
math.
May.
Okay, so it's so good planning. Okay, so it can be a good strategy to have a successful pregnancy and delivery. So these are the sets of medications they'll be on. So because it's autoimmune, they'll take immunosuppressants. For the flare-ups, they'll be on steroids. Monoclonal antibodies are very expensive treatments, but if your insurance covers it, let's say spouse or you work in with the government, no, let's say Congress, Congress people have very good insurance, so they'll cover monoclonal antibody treatments. Antimalarials, have you heard of hydroxychloroquine? Was very famous in 2020. No, as the with COVID, okay, and they were talking about that, and with horse tranquilizers and everything. So hydroxychloroquine is believed to decrease flare-ups. Okay, they basically, how the drug works, it decreases the skin's ability to absorb ultraviolet rays. So therefore, if it does that, then will we have flare-ups? Less flare-ups as a result. Okay, so that's how the hydroxychloroquine works. NSAIDs, as already mentioned, but again, most of the drugs here will be immunosuppressive agents. Here's one of the expensive monoclonal antibodies, very effective, but again, also very expensive. Steroids, they also come in topical, for the butterfly rash. You can also apply topical steroids there. So IV steroids, again, are for exacerbations, for flare-ups. And again, we already discussed Cushing syndrome and the effects all throughout the body, including osteoporosis and fractures. Okay, so here's hydroxychloroquine. This is also teratogenic, so careful with, again, pregnant women. Avoid pregnancy while on it. And here are the everyday.
Didn't you want me to put the syringes?
So these are the drugs, cyclophosphamide. Some of them will be familiar. We've come across mycophenolate, right? For organ rejection earlier. So here it is again. So they're similar because, the same nature, right? You give drugs to suppress the immune system, so they'll likely be used for other purposes besides organ rejection. You've seen methotrexate before, right?
Yeah.
Last semester for rheumatoid arthritis. Okay, so very cheap drug, to very cheap immunosuppressant. So our nursing management is geared toward educating the patient and managing side effects due not only from the disease, but also the treatments. Imagine all of the medications these patients are taking. Some of these, let me mention, azathioprine, or I think the brand name is Imuran. Also very common in younger patients. They take these a lot. I see that prescribed a lot. They did not mention because we have, no, sorry, I'm thinking about multiple sclerosis. Never mind. So these are the drugs used for SLE. And here's a chart for your nursing care. So from pain to fatigue to impaired mobility. So when these patients have a flare-up, they're basically disabled. They cannot go to work. And we don't know how long that flare-up will last. It's a challenge, again. So you're between 20 and 40. What are you doing between 20 and 40?
Working.
Yeah, so you're in school, right? You're getting married, starting a family, and then you deal with this disease. So besides the physical illness, what else will the patient develop here?
Mental.
Okay, so we've got depression, anxiety, etc. And that's about it for lupus.
Lupus